everyone, this is Dr. Tazeen, and I'm here with RRR Series for all the aspirants who are preparing for their MRCOG Part 1 exams. And we are going to discuss few important topics which are very important in the clinical management aspect of your exam. And we will try to make it easier for you. So if you have not subscribed the YouTube channel of Study Medic, you should subscribe the YouTube channel and just click on the bell icon so that you can stay updated with all the new updates and all the new RRR series sessions. Before start of session, just keep one thing in mind that the key to success is passion and dedication. Keep your passion and dedication alive, and definitely you will be able to achieve your goals. And now just very few days, last 1 week to your exam. So put all excuses aside and just remember one thing, that you are capable of passing this exam, and definitely you will be able to pass this exam with flying colors. What we are going to cover in this short session of RRR series is that how to manage pregnancy of unknown location. What about ectopic pregnancy? What are various types of miscarriages and what can be the management? And the important aspects of gestational trophoblastic disease. So, first of all, ectopic pregnancy is basically any pregnancy where the fertilized ovum, it gets implanted and it develops in a site which is other than uterine cavity. So, pregnancy outside the uterine cavity, that is known as ectopic pregnancy, and it represents a serious hazard to a woman's health and reproductive potential. These are not normal pregnancies. If they are not treated, they can end up in life-threatening situations if this pregnancy ruptures. So the management of these pregnancies is very, very important. They are 1 to 2% of total pregnancies. However, the recurrence is higher, and the recurrence rate is 18% after one ectopic pregnancy. So where can be the sites of these ectopic pregnancies? These can be extrauterine, outside the uterus, or they can be uterine, like inside the uterus, which can be cervical pregnancy, cornual pregnancy, or cesarean scar pregnancy. And the incidence of these is less than 1%. Extrauterine can be tubal pregnancy, and among the tubal pregnancies, 70% is in the ambulatory region of the fallopian tube. That can be in the isthmic region of the fallopian tube in 12% of the cases, in fundibulum and interstitium in 2% of the cases. Ovarian pregnancies can also be there, and same is the situation with abdominal pregnancy, that this pregnancy can implant inside the abdomen. So abdominal ectopic pregnancy can also be there, which you should remember. So there is classical triad for the presentation of acute ectopic pregnancy. 50% of the patients, they present with ruptured ectopic pregnancy, and the most constant feature is the pain in 95% of the cases. Remember one thing for your exam, that when the patient who presents with miscarriage, bleeding is more and pain is less. When a patient presents with ectopic pregnancy, then pain is significant while bleeding can be just spotting, brownish spotting, or just spotting can be there. So these are the two things where you can differentiate in the scenarios for your exam. So shoulder tip pain can be there, which is the referred pain due to diaphragmatic irritation from the hemoperitoneum. 60 to 80% patients can present with amenorrhea, as this is a ectopic pregnancy. So definitely these patients, they present with amenorrhea and vaginal bleeding, which usually is scanty and dark brown. So most of the time these patients, they present with spotting. So remember the classical triad of pain, amenorrhea, and vaginal bleeding. This can be the same in miscarriages, but one thing you have to remember is that in the miscarriage, pain would be less significant, bleeding would be more, and in case of ectopic pregnancy, there would be less bleeding, just like spotting, and pain would be more significant. The management of ectopic pregnancy can be in three ways. It can be expectant management. Expectant management means doing nothing, living on nature. However, measuring or following the pregnancy hormone, which is beta HCG. Medical management and then surgical management can also be there. So there is basically selection criteria. It all depends upon the situation, that what is the clinical situation of the patient, whether they are stable or they are not stable, how vitally, what is the pulse rate or temperature, blood pressure of the patient, then how about their clinical symptoms of pain. Okay, and hemodynamic stability is important. Pregnancy hormone levels are important to decide about the selection criteria of management. And then also patients' wishes, definitely they are also important. If they are willing for follow-up, we can keep them on the medical management. If they are not willing or it is difficult for them to follow up, then we may need to go for surgical management. And also the ultrasound features are very, very important, that what is the gestational sac size, whether fetal cardiac activity is present in the gestational sac or not. And always remember for your exam that wherever the fetal cardiac activity is present, then you have to remember that in that situation you have to go for surgical management of ectopic pregnancy. So if there is minimal symptoms and the patient is hemodynamically stable, there are no signs of active bleeding, there is absent fetal cardiac activity, and the patient is having normal complete blood picture, renal function tests and liver function tests are within the normal range, we can go for medical management. Why the blood tests are important? The significance is that this methotrexate, which we are giving for medical management of ectopic pregnancy, this can actually cause myelosuppression and it can be nephrotoxic and hepatotoxic. So that's why these blood investigations are carried out before prescribing methotrexate to the patient. If the patient is having difficulty or unwillingness for the follow-up, so then these are not the good candidates for medical management. Same is the situation if the size of the ectopic pregnancy is more than 3.5 centimeter, and if the fetal cardiac activity is present, then also they are not good candidates for medical management. Surgical management is carried out. So now you know the medical management. We say hemodynamic stability. We say that the size should, sac of the size should be less than 3.5 centimeter. And we say that fetal cardiac activity should be absent. So what would be the surgical management indications? If you go opposite to that, that patient is hemodynamically unstable, okay? So they are having the gestational sac size, which is more than 3.5 centimeter. They are having the pregnancy hormone beta HCG level more than 5,000, or you can say that the fetal cardiac activity is present in the gestational sac. In that situation, we may need to go for surgical management of ectopic pregnancy. Surgical management can be in the form of salpingotomy. If we want to conserve the tubes, an incision is made in the tube and then only the pregnancy tissue is removed. However, there can be risk of remaining trophoblastic tissue in, so we need to follow up these patients, and there can be recurrence in the next pregnancy as well. Segmental resection and anastomosis can be carried out. Milking and fimbrial expression can be carried out. And salpingectomy is the principal treatment which is carried out in ectopic pregnancies. If the other contralateral tube is healthy, then salpingectomy is the procedure of choice which should be carried out in case of ectopic pregnancy. So, what is the protocol for the methotrexate, which is very, very important, and how we have to follow up? So, it is basically we are following up on day 1, 4, and 7. So, what actually we are measuring on these days: beta HCG, electrolytes, and LFTs, full blood count, blood group, and the dose is 50 milligram per meter square intramuscular methotrexate. On day 4, we will measure beta HCG levels, and on day 7, we will be measuring beta HCG levels. And if the decrease is less than 15% days 4 to 7, we can repeat transvaginal scan and methotrexate second dose can be given. And if the beta HCG level decrease greater than 15%, so then we can repeat beta HCG levels weekly until the level is less than 15 international units per liter. Okay, so how we are following up, what we are doing on the follow-up, we are measuring beta HCG levels, and what would be the criteria to see that whether the patient needs another dose of methotrexate. or they are not needing any further dose of methotrexate, that would be the fall in the beta HCG levels, less than 15% or more than 15%. All right. So then one more important thing is that contraindications to methotrexate. Contraindications to methotrexate are hemodynamic instability, presence of an intrauterine pregnancy, breastfeeding, unable to comply with follow-up. If the patient is unable to, as I discussed, that patient is unable to comply with the follow-up. If it is chronic liver disease, okay, and if it is pre-existing blood dyscrasias, as we discussed that we were doing CBC, LFTs, RFTs. So we need to rule out the presence of blood dyscrasias, as methotrexate already cause myelosuppression. Active pulmonary disease, if it is there, that is also very important that we should keep in mind, and peptic ulcer disease should also be kept in mind. So how to follow up and what are the contraindications of methotrexate? They are very important, so it should be kept in mind. So moving forward to the next topic, so that is pregnancy of unknown location. That is when a woman has positive pregnancy test, but we are unable to see pregnancy on transvaginal scan, and there is no intrauterine pregnancy, but the pregnancy hormones tells that this patient is having pregnancy, and the pregnancy hormone levels are higher. Beta HCG levels are higher, but we are unable to see pregnancy. So there can be three situations when we are unable to see the pregnancy. This can be normal intrauterine pregnancy. So on the next follow-up, this can be normally growing intrauterine pregnancy. This can be ectopic pregnancy, or this can be a miscarrying pregnancy, which we have to rule out the possibilities that which type of pregnancy it is. When we are doing the early pregnancy ultrasound, so we will see that if the pregnancy is present, so we have to see that this is viable intrauterine pregnancy, and the routine pregnancy care would continue. So if we are for fetal cardiac activity is not present, then we need to see that whether the fetal poles are present or not. If the fetal poles are present, we will measure the crown rump length, CRL. If it is less than 7 mm, we will repeat the scan after 7 days, as there can be possibility that we will be able to find out the normal growing pregnancy. And if it is equal to 7 mm, then second opinion immediately by the second sonologist can be taken, as if it is more than 7 mm and no FCA is present, no fetal cardiac activity is present. This, if after two opinions, this can be miscarriage. Okay, in the same way, we will have a look at the we will have a look at the fetal poles, and if the fetal pole is not seen, and we will have a look at the gestational sac. Okay, so gestational sac, if it is less than 25 mm and there is no fetal pole that is seen, so we can repeat the scan in 7 days. If, however, it is equal to 25 or more than 25, but no fetal pole is there, then we need to seek second opinion to give the patient benefit of doubt, and then this can be labeled as miscarriage. But always remember that two sonologist opinions are needed to label the patient as miscarriage. So here there is one question which is exam tested question, that which one of the following ultrasound description is diagnostic of miscarriage: gestational sac, crown rump length, fetal heart rate. So the option A says that mean gestational sac diameter 25 mm with no obvious yolk sac. All right, so this seems right. Mean gestational sac diameter 25 mm containing fetal pole and CRL 3 mm. So there is a huge disparity, and gestational sac having fetal pole 25 mm, we cannot label it as miscarriage. Gestational sac diameter 40 mm, that is way more than the discriminatory zone, and CRL is 7 mm with evidence of fetal heart rate. This cannot be miscarriage when there is evidence of fetal heart rate. No identifiable intrauterine or extrauterine gestational sac, and beta HCG is 200. So this can be we are not able to label it as miscarriage. Okay, so as the beta HCG levels are very less, 200, and there is no identifiable sac, no identifiable intrauterine or extrauterine sac, and beta HCG is 1500 international units. So that is also that we have to decide on the presence of gestational sac, CRL, fetal pole, and fetal cardiac activity. All right, so here the answer is that mean gestational sac diameter 25 mm. When the gestational sac has reached 25 mm, but there is no yolk sac, there is no fetal pole, we can say after second sonologist opinion that this is miscarriage. Okay, so diagnosis of miscarriage, just one ultrasound scan cannot be guaranteed to be 100% accurate. That's why second opinion is important. And always remember the cutoff CRL 7 mm and gestational sac diameter 25 mm, which should be kept in mind, which is very, very important to remember. Okay, so viable intrauterine pregnancy, too small to visualize, and failed pregnancy of unknown location, which is early miscarriage that resolves spontaneously. Ectopic pregnancy, persistent pregnancy of unknown location, which is ongoing but location remains unknown. That is known as pregnancy of unknown location. Unknown location means that the pregnancy test is positive, but location is not known. Ectopic pregnancy is outside the uterus, and viable intrauterine pregnancy means that pregnancy test is positive and pregnancy is inside the uterus. The investigations which we can carry out is beta HCG levels, transvaginal scan, and clinical assessment of the patient is very, very important in all early pregnancy problems, like how the patient is presenting. They are presenting with pain, bleeding is there, or hemodynamic instability is there. That is also very important. So beta HCG less than discriminatory zone, if it is there, so we need to repeat beta HCG in 48 hours. If the beta HCG rise, so now we have to see when we are actually measuring the beta HCG, which is known as pregnancy hormone. So when we are measuring the beta HCG, we have to see that it is markedly decreasing. That can be failing pregnancy. It is suboptimally increasing. The rise is there, but that is not the rise which should be expected in normal pregnancy. That can be ectopic pregnancy, as in the ectopic pregnancy, that can be, the beta HCG rise in pregnancy of unknown location and ectopic pregnancy is suboptimal, and beta HCG is increasing markedly. That can be normal intrauterine pregnancy. So we always see the trend of beta HCG, that how is the trend of beta HCG, which we have to follow. Okay, if the beta HCG levels are rising and it is more than 66%, so this can be, intrauterine pregnancy, and we need to repeat ultrasound scan. Beta HCG level more than 50% in 48 hours. So this can be failed pregnancy of unknown location. We need to follow until beta HCG gets negative. And beta HCG plateaus or rises abnormally, possible ectopic or non-viable further imaging, consider uterine curettage. That is important. So pregnancy of unknown location, if it is there and patient is hemodynamically stable, we may need to do the beta HCG levels. If, however, there is pain, then we may need to do laparoscopy as well. If the patient is hemodynamically stable and pain-free, then expectant management can be carried out. Expectant management always means living on the nature, and we shall be measuring the beta HCG levels and we will be repeating it at 48 hours. If, however, the patient is hemodynamically unstable, then we need to do the laparoscopy or laparotomy, depending upon the expertise available, as the patient's hemodynamic instability may be ruptured ectopic pregnancy or some problem. So that needs to look after, and that's why the exploration is important in such cases. All right, so this is pregnancy of unknown location. When the pregnancy test is positive, but we are unable to see pregnancy, so we have to follow through the pregnancy hormone levels, followed by scan, that how the pregnancy outcome can be and what type of pregnancy it is. The third thing is miscarriage. So miscarriages can be of various types, and they are basically defined as early miscarriage, late miscarriage, threatened miscarriage, complete or incomplete miscarriage, or missed miscarriage. Early miscarriage is a loss of pregnancy in the first 12 weeks of gestation. Okay, and late miscarriage is loss of pregnancy after 12 weeks of gestation, but before 24 weeks of gestation. Why the cutoff 24 weeks? As 24 weeks is the viability, age of viability, that is important. Threatened miscarriage is basically that ongoing pregnancy with the presence of vaginal bleeding. So pregnancy is there, but the patient is developing bleeding, so that can be threatened miscarriage, as there is possibility of miscarriage. Complete miscarriage means that a loss of pregnancy where all the pregnancy tissue has been removed or expelled. Okay, and incomplete miscarriage is that pregnancy loss where partially the products of conception have been expelled and partially they are present in the uterus. So the name indicates that this can be incomplete miscarriage. And missed miscarriage, a loss of pregnancy where the embryo or fetus has died without associated bleeding or pain. We on the scan we say that a sac is there, but we are not able to focus that this embryo or the pregnancy has died, but there is no bleeding, nothing is there. So that is known as missed miscarriage, which is found. Inevitable miscarriage means bleeding is there, the os is open, cervical os is open, so but the pregnancy tissue is inside the uterus. So it means that now the bleeding has started, the cervical os is open, so it would be very difficult to prevent this miscarriage. So that is known as inevitable miscarriage. And recurrent miscarriages are when there are two or more pregnancy losses, consecutive pregnancy losses before 24 weeks of gestation. So that is basically named as, you can say that that is recurrent miscarriages. There can be certain risk factors for the miscarriages. So these miscarriages are increasing maternal and paternal age, number of previous miscarriages, race and ethnicity, occupational and environmental factors, exposure to pesticides, heavy meals, excessive air pollution, lifestyle factors can be there, and certain medical conditions and medications can also be there. So, what can be the things which can be associated, or differentials which can be associated with miscarriage? Pregnancy related, this can be ectopic pregnancy, molar pregnancy, ruptured ovarian cyst can present in the same way, abdominal pain and bleeding, ovarian torsion, degeneration of fibroid. Non-pregnancy related can be trauma to the cervix, vagina or vulva, cancer of the cervix, vagina or vulva, other conditions affecting the cervix, ovarian cyst, torsion of the fibroid, hemorrhoids, urethral bleeding, vaginitis, musculoskeletal pain, urinary tract infections, constipations, irritable bowel syndrome, pelvic inflammatory disease, appendicitis, renal colic, bowel obstruction, pelvic pain. So all they can present in the same way. So the management can be expectant, leaving it on the nature. When the patient is stable and patient's preference is there, patient is willing for the expectant management. If they develop heavy bleeding, they have to report back to the hospital. Medical management is misoprostol and mifepristone to induce expulsion. To those patients who are willing for the medical management and they don't want surgery, so medical termination can also be one of the options. And surgical is manual vacuum aspiration or evacuation and curettage. Heavy bleeding if it is there, if infection is there, and if the patient wants definitive treatment or patient wants surgical treatment, then it can be carried out. Complications can also be there, that there can be risk of infection, for that's why antibiotics are given to these patients who are at high risk. And if the patient develops fever, uh, foul smelling discharge, breathlessness, tachycardia, so that should be kept in mind that this can be associated with sepsis, excessive bleeding, foul smelling bleeding, pale, clammy or dizzy, increased heart rate can also be there, which is showing hypotension, and that should be also considered. Venous thromboembolism patients, they can present as leg swelling and leg pain. Shortness of breath can be there, and red and blue discoloration of the skin, sudden breathlessness, chest pain. So the possibility of clot formation can be there. So that's why they should be assessed for venous thromboembolism. And emotional well-being of the patients in cases of miscarriage is very, very important, as they should be provided support as most of the time the patient they feel guilt and they blame themselves, so that should be kept in mind, and appropriate support for the patients, it should be there. Then there comes gestational trophoblastic disease. Gestational trophoblastic disease is basically, this can be complete molar pregnancy, this can be partial molar pregnancy, and the differentiating two, that is your exam question. Okay, complete molar pregnancies are diploid pregnancies, androgenic in origin, 70 to 80% as a consequence of duplication of a single sperm following fertilization of an empty ovum, and 20 to 25% are dispermic fertilization. Partial molar pregnancies are basically, they are a normal haploid is fertilization by more than two sperms. 90% are triploid in origin, evidence of fetus and fetal RBCs. 10% are tetraploid in region, and they almost all occur by dispermic fertilization. The most common feature of molar pregnancies is irregular bleeding, which is your exam question as well, that most of the molar pregnancies they present just like the miscarriages present with bleeding. Positive urine for pregnancy test is there, and ultrasound features of molar pregnancy are there. Less common features can be hyperemesis, excessive uterine enlargement, hyperthyroidism, early onset preeclampsia, and then there can be abdominal distension, and hemoptysis and seizures can also be. The molar pregnancies are basically, the definitive diagnosis is by histological examination when we remove the pregnancy and we send it for histopathology. 35 to 40% correctly identified before 14 weeks of gestation, and 60% are identified after 14 weeks of gestation. When there is absence of fetal tissue, excessive hydropic changes to the villi are there, and excessive trophoblastic proliferation is there, we should suspect molar pregnancies. This can be complete molar pregnancies in which no fetal tissue is present, and partial molar pregnancies, fetal tissue can be present. So focal hydropic changes to the villi and some excess trophoblastic proliferation. Ploidy status and immunohistochemistry staining for P57, a paternally imprinted gene, may help in distinguishing partial from complete molar pregnancies. Then there can be complete or partial molar pregnancies, which are known as high density deformed mole. The management is suction curettage is the first line management. Oxytocic agents should be avoided until and unless there is life-threatening bleeding. If there is life-threatening bleeding, then they can be considered. If the patient is Rh negative, NTD should be considered, and follow-up of the patient is weekly until beta HCG level returns to normal, and then for 6 months. And reliable contraception is important. Intrauterine contraceptive device should be avoided. However, OCPs can be given once the beta HCG level has returned to normal. In case of invasive mole, chemotherapy is the treatment, which is methotrexate or actinomycin D. Surgical intervention if the patient is resistant or if complications are there. Choriocarcinoma is basically staged as per FIGO staging, and the scoring is carried out. If the score is less than 6, then single agent chemotherapy is given, methotrexate or actinomycin D. If the FIGO score is more than 7, then multi-agent chemotherapy can be given, so which is EMACO, etoposide, methotrexate, actinomycin D, cyclophosphamide, or vincristine. Beta HCG levels are monitored after the treatment, and long-term follow-up is needed for these patients. Placental site trophoblastic tissue is less responsive to chemotherapy, and the surgical management in the form of hysterectomy is the treatment for these patients having placental site trophoblastic tissue. So when a patient is coming to you with molar pregnancy, so suction curettage is the treatment of choice. Beta HCG is monitored 48 hours after the curettage, and then 1 to 2 weekly serum beta HCG levels are carried out. If this returns to normal within 56 days after evacuation, then it is followed for 6 months from the date of evacuation. And if this becomes normal after 56 days of evacuation, then it is monitored for 6 months from the date of beta HCG normalization. So this point is very, very important, that if it becomes normal within 56 days, then you will follow up for 6 months from the date of evacuation. And if this becomes normal after 56 days from evacuation, then it is measured for next 6 months from the date of normalization. And this is how we measure the FIGO scores. It depends upon the age, antecedent pregnancy, interval months from the end of the index pregnancy, pre-treatment beta HCG levels, size of the tumor, size of the meds, number of meds, and previous failed chemotherapy. And the scoring is carried out as 0, 1, 2, and 4. And as we discussed, if the score is less than 6, that would be single agent chemotherapy. If the score would be more than 6, that would be multi-agent chemotherapy. So here the exam question comes that a woman has been diagnosed with a high-risk gestational trophoblastic neoplasia and she is about to receive multi-agent chemotherapy. What would be the expectant cure rate? So they want to know that what would be the expectant cure rate we should know that what would be the cure rate with single agent chemotherapy and what would be the cure rate with multi-agent chemotherapy. So with the single agent, it is 100%, and with the multi-agent, it is 95%. You can say in other way around that if the FIGO score is less than 6, as on the less than 6, we are going to give single agent chemotherapy. So, and the success rate is 100%. If the FIGO score is more than 7, we are giving multi-agent chemotherapy and the cure rate is 95%. 36-year-old woman had suction evacuation because of a complete molar pregnancy. Her chorionic gonadotrophin levels started to rise 6 months after the treatment. FIGO score was 6. What is your management? So if FIGO score is 6, less than 6, we are going single agent chemotherapy. More than 6, we are going multi-agent chemotherapy. So here the answer would be single agent intramuscular methotrexate as the score is 6. So we have to remember for this that when we are giving single agent chemotherapy, the success rate is 100 in case of FIGO score less than 6. When we are giving multi-agent chemotherapy, when it is score is more than 7, the success rate is 95%, which should be remembered. So this was all about your early pregnancy complications, which are the important exam tested areas as far as clinical management of early pregnancy problems is concerned. And we wish you all the very best. Stay tuned for further YouTube series and subscribe to the YouTube channel. Thank you so much.